Welcome to our high-yield clinical cases, covering key topics in orthopedics, respiratory, and cardiology.
All right, let's jump right in. Our first section looks at joint disease, and we're going to contrast the really crucial differences between degenerative and inflammatory problems.
And kicking things off, we have case number 1, osteoarthritis.
So picture this. Your patient comes in and their main complaint is joint pain that just gets worse and worse as the day goes on. That is the absolute classic sign of OA. It's right there in red, pain that worsens with use. This tells you everything you need to know about its pathology. It's a wear and repair problem. Think of it as mechanical stress breaking down that cartilage over time. It's not a big inflammatory storm, which is why the morning stiffness is pretty minimal, usually lasting less than half an hour. And when you look at the hands, you're going to see it in those classic spots, the DIPs and PIPs, and really importantly, at the base of the thumb.
Okay, now the X-ray findings are where the story really comes to life. You'll see the joint space getting narrower because the cartilage is wearing away. In response to that stress, the bone starts to react. It gets thicker, that's subchondral sclerosis, and it can form cysts. But the real telltale sign, the one highlighted here, is the formation of bony spurs called osteophytes. Management, then, is all about handling the symptoms and keeping the person moving. We start with simple pain relief, maybe add NSAIDs for bad flare-ups, but the real clinical pearl here, in green, is to avoid immobilizing the joint for long periods. Motion is lotion for these joints.
So let's just boil this down. Osteoarthritis is degenerative. You lose cartilage, and the bone reacts by building more bone, those osteophytes. But, and this is a huge contrast, inflammatory arthritis is all about synovitis. The joint lining is inflamed, and it actively eats away at the bone, which leads to osteopenia. So one builds bone where it shouldn't, the other destroys it. It's a completely different process.
All right, case number 2. Let's talk about polymyalgia rheumatoidica. This is a big one, a systemic inflammatory condition that can seriously fool you into thinking it's just some muscle aches and pains.
The classic story for PMR is an older patient who suddenly develops this really intense, symmetrical aching and stiffness, specifically around the shoulders and hips. They'll tell you they can't get out of a chair or even comb their hair. Now, the lab test that screams PMR is a hugely elevated ESR, often over 50, a major sign of inflammation. But here's the absolute do-not-miss point. It's strong link to giant cell arteritis. You have to ask about headache, pain when chewing, and any visual changes. Missing this could literally cost your patient their vision.
You know, since we're talking about inflammation and NSAIDs, let's just quickly clear up a really common misunderstanding about their side effects. A lot of people think it's just about local irritation in the stomach. But that's not the whole story. The real issue is systemic. It's called COX inhibition. When you block these protective prostaglandins all over the body, you get the risk of GI ulcers, yes, but also sodium retention and, critically, reduced blood flow to the kidneys. And that's why using a suppository or just taking a pill with food doesn't get rid of these serious systemic risks.
Okay, moving on. Let's look at a key physical sign that can be a major clue to some serious underlying systemic disease.
And that sign is finger clubbing. The mechanism behind clubbing is just fascinating. It's a perfect example of how an outward sign can reveal something big happening inside the body. The leading theory is that tiny fragments called megakaryocytes, which normally get filtered out by the lungs, are somehow bypassing them. They end up getting stuck in the tiny capillaries of the fingertips. There, they release growth factors, which then cause all this extra tissue and blood vessel growth that we see as clubbing. Now, for your exams, the single most important thing to remember in an adult with new clubbing is its association with lung cancer, especially squamous cell carcinoma.
All right, let's switch gears completely and head over to cardiology. It's time to tune our ears and decode a couple of classic heart sounds. We're going to start with the very distinct sounds of mitral stenosis.
Listening to a heart with mitral stenosis is like hearing the valve tell its story of struggle. First, you get a loud S1. That's the sound of those stiff, calcified valve leaflets slamming shut. Then comes an opening snap. That's the stenotic valve being forced open by all the pressure building up in the left atrium. That's followed by a low-pitched, rumbling murmur in mid-diastole, which is the sound of blood struggling to get through that narrowed opening. And finally, if the patient is in a normal rhythm, you might hear a pre-systolic accentuation. That's the atrium giving one final kick to push the last bit of blood through. Every single sound tells a piece of the story.
All right, next up is a sound that can be totally harmless or a sign of something very serious, the third heart sound, the S3.
The S3 is this low-pitched sound you hear early in diastole. Some people say it sounds like a gallop. What's making that sound? It's the sudden slowing of blood as it rushes into a ventricle that's either really stiff or already full of blood. Now, here's the high-yield part you have to know. In someone young, under 30, an S3 can be totally normal. But, and this is highlighted in red for a reason, if you hear an S3 in someone over 40, you have to assume it's pathological. It's a huge red flag for left ventricular failure or severe mitral regurgitation. And here's a great clinical pearl. Because this sound is caused by passive filling of the ventricle, it doesn't go away even if the patient is in atrial fibrillation.
For our last section, let's tackle a critical scenario. What happens when the heart's own electrical grid just fails?
So, let's set the scene. You've got a patient in front of you, and their pulse is a dangerously low 32 beats per minute. What's immediately jumping to the top of your list of possible causes?
When the heart rate is that low, you have to shift your thinking away from metabolic causes and straight to the heart's electrical system. Sure, you might think of other things, but conditions like Addison's or an insulinoma are just not going to cause this severe of a bradycardia. The diagnosis that should be staring you right in the face is a high-grade AV block. This isn't a problem with hormones or blood sugar. This is a wiring problem, plain and simple.
And this leads us to our final and most critical case, complete heart block that's now causing acute heart failure.
So let's just walk through what's happening here. In complete heart block, the electrical signal from the atria is completely cut off from the ventricles. They're totally dissociated. The ventricles, left to their own devices, start beating at their own very slow escape rhythm. And just look at that equation. If you tank the heart rate, your cardiac output plummets. When that happens, the body isn't getting enough blood, and fluid starts to back up. That's heart failure. The electrical problem has officially become a pump problem.
Understanding that pathophysiology tells you exactly what you need to do. You're not just treating the symptoms of heart failure here, you have to fix the root cause. And that means you have to restore the rate. The #1 absolute life-saving priority is to get a transvenous pacemaker in urgently. You can give diuretics carefully to help with the fluid, sure, but you have to avoid drugs like digoxin, which can make the heart block even worse. So the final takeaways is simple. When the pump is failing because the electricity is out, your first job is to turn the power back on. You must restore the rate.